As being co-director of the Jefferson Pancreatic, Biliary, and Related Cancer Center, virtually almost 100% of my laboratory works on pancreatic cancer. We do work within our signaling pathways on other tumor systems, such as ovarian cancer and some melanoma, but primarily we focused on pancreatic cancer, the aggressiveness of the biology behind it, the molecular biology behind it, so how it develops, and as well as how it becomes resistant to different therapeutic strategies. Here at Jefferson, we try to look at this from all fronts. This has to be a disease that we tackle from multiple fronts. And the reason I talk about that is you have to start with also having an early detection strategy. We have reason to believe that some areas of the genome that have been unexplored could potentially be nice markers for pancreatic cancer predisposition syndromes, as well as be able to detect high-risk individuals. And if we can detect those individuals early enough, we could actually bring them to the operating room where Dr. Yo and Dr. Jordan Winter and Harish Lavu could operate and potentially remove some of these precursor early pancreatic cancer lesions before it becomes a death sentence. Another way that we're very interested in my laboratory is how do these pancreatic cancer cells avoid and adapt to the chemotherapy and the therapies that we give them. They seem to have a lot of, I call them airbags, that release and protect themselves against chemotherapy. And these we think can't really be explained by simple genetics. They're actually, it's a little bit more complicated. What we study is more how RNA changes. And these are very rapid and fast changes that the pancreatic cancer cell uses to adapt, let's say, from being in a very robust setting to more of a desert, where it has to quickly to adapt to very little nutrients and water, if you will. And so the pancreatic cancer cells use this ability to do this. In fact, we also have a grant in which pancreatic cancer cells find ways to avoid the immune system. And we're trying to find ways in which to make those pancreatic cancer cells not adapt to these therapies and sort of make these tools, if you will, that the pancreatic cancer cells use, these molecular tools to avoid the therapy, we're trying to make them now actually Achilles heels, so then we can actually tackle them and make either current therapies better or design new treatment options. Part of the problem, getting back to it, I mean, this is an important point, is, first of all, prostate cancer, the 5-year survival basically for someone who's diagnosed for prostate cancer is nearly 100%. For pancreatic cancer, now it's 7%. Part of it is just early detection strategies. Part of it is that by the time the patient shows up at their internist, they're either jaundiced or feeling back pain. Pardon the bad metaphor, but the cat's out of the bag. It's become metastatic, and it just become too late. And a lot of these other cancers that you've mentioned, these solid tumors, as long as they haven't become invasive and by definition truly malignant, these cancers are ones that we can start treating. Now there's been a huge revolution in the use of basically educating and also modifying the immune system to attack other tumor systems. In fact, it's been a game changer. We've yet to see that success in pancreatic cancer. I think one is that we're detecting it maybe too late and the immune system may not be able to adapt. Two, this is a very complex tumor. When we think of these other tumors, they're actually almost purely tumor cells. The pancreatic cancer tumor is full of a complex milieu of a number of different types of cells. Fibroblasts, stellate cells, a number of different, what we call, a stromal reaction, desmoplasia. There's a lot of microenvironment there embedded around the tumor cells. And there's a nice healthy academic debate whether those tumor cells are actually, that microenvironment is actually keeping the tumor at bay, or whether it's just truly should be part of the beast that we're tackling, or whether it actually is protecting the tumor cells from therapies getting to the tumor cells. It's basically, if you will, a facade for the tumor cells. I think all these factors, from late detection to the fact that we're dealing with a very complex beast, much more complex than the other tumor types, to the fact that the immune system might have a more difficult time getting there or recognizing these tumor cells. I think these are all reasons why we've seen a lot of successes in these other tumor types, and yet we haven't seen those dramatic differences in clinical outcome.